Hi, welcome everyone. We'll get started in just a few more minutes and give people a chance to log on and get ready to go. Welcome everyone. It is now noon and it looks like we have a number of folks that have joined us in the Zoom, and we have started broadcasting live on Facebook. So let's get going. First of all, on behalf of the Washtenaw County Health Department, welcome and thank you for joining us. This is the second segment in our Cannabis in Practice virtual series. As folks probably realize, this was initially supposed to be an in-person conference, and due to COVID, we have pivoted and created a virtual conference. And so we're glad folks can still join us. This educational event and series is made possible with funding from the state regulatory agency for marijuana. And I'm covering up my notes, so I want to get their acronym correct. It's LARA, the Department of Licensing and Regulatory Affairs, and they have a marijuana regulatory agency. So we get this funding specifically for education and outreach on medical marijuana, and it can't be used for any other purposes, but we also recognize that there is a lot of increased need for education among both practitioners and the public as things change in the regulatory environment and the healthcare environment around cannabis. So with no further ado, let's get going. We have put in the chat our webpage if you want information about the other segments in this series, and we welcome everyone to ask questions as we move forward in the chat box, and we will be giving those to our presenter. I'm going to turn it over to Gabrielle with the Washtenaw County Medical Society, who is working closely with us on this series, and she will introduce our speaker for today. Thank you.
Thank you, Susan. As Susan said, my name is Gabrielle Schlenker. I'm the Executive Director of the Washtenaw County Medical Society, and we are proud to represent more than 1,000 physicians and medical students across this great county. I have the pleasure of introducing today's speaker, Dr. John Hopper. Dr. Hopper graduated from the Wayne State University School of Medicine and completed residency in combined internal medicine and pediatrics at the University of North Carolina, where he served as co-chief resident in pediatrics. From 1994 to 2005, he served on the faculty at Wayne State and was medical director for psychiatry's research division on substance abuse. From 2005 to 2008, Dr. Hopper served as chief medical officer at Brighton Hospital. Dr. Hopper directed the internal medicine residency and addiction medicine fellowship at St. Joseph Mercy Hospital, Ann Arbor, from 2008 to 2015. He currently works for the Accreditation Council on Graduate Medical Education and continues to work clinically at St. Joseph's Ann Arbor through Integrated Health Associates, IHA, and is a very proud member of WCMS's Executive Council. Thank you very much, Dr. Hopper. I'm turning it over to you.
Thank you very much, Gabrielle and Gabrielle. Thanks everyone for joining this series on cannabis today. As you know, I'm John Hopper, and we're going to talk about adolescent cannabis use in clinical practice. These are my employers. I have no financial disclosures for this presentation. I want to mention a couple things that we're not going to discuss today. Obviously, cannabis is a very broad topic. As you know, there's many forms of cannabinoids. There are different delivery systems. There's varying legality. This whole topic in and of itself was actually a talk that I did at a national conference on addiction. Here's a slide from it. That's out of the scope of really what we're going to talk about today. Today, we're really just going to talk about the clinical approach for adolescent marijuana use, which is invariably a problem, despite what your patients will tell you. It's not legal for adolescents to be using any forms of cannabinoids, and all of them have similar problems, although the consequences for some, such as the synthetic cannabinoids, can be very serious. And there really is a lot to be said about adolescent marijuana use, and one person who's really shaped our knowledge and thinking is Nora Volkow, so you'll see her name and her image throughout many of these slides today. She's the current director of the National Institute on Drug Abuse. Dr. Volkow really has shaped our thinking, and at the same time, we have to recognize that a lot of our knowledge is incomplete and emerging, particularly in terms of health consequences of cannabis use in adolescents. But we'll do our best to address both the health consequences today as well as the clinical approach to motivating adolescents to change behavior, and then also thinking about treatment and public health approach at the clinical level. I do have to mention my perspective because ultimately that it's going to create some bias in regard to this talk. As you heard, I was trained in internal medicine and pediatrics. I have decades of experience in primary care as well as specialty care of addiction, both in the hospital as well as in outpatient practice. And as an addiction specialist, I'm used to working with patients who have fallen off the healthcare cliff. They're really at their end of their rope. And today, really, we're thinking about working with adolescents where we have the opportunity to intervene before adolescents get too close to the edge of that cliff. And that's really what our focus is here today. To start, I want to illustrate a case who's not an adolescent, but a patient I saw in primary care, Mike. Mike was an all-American father of three. He didn't look quite like Boris Beckham, which we have in this picture here, but he's a good guy, and he had a terrible disease of addiction. And in my primary care relationship with him, I discussed addiction with him many times. But one day he came to the office and said he finally wanted help with this problem. And he told me the final straw had happened on a day when he was supposed to pick up his kids from soccer practice. There were severe thunderstorms. He knew practice would end early. But before he went to the soccer field, he had to go and stop and pick up his drugs before getting his kids out of the lightning and the pouring rain. So this really here is the definition of addiction. He's using a drug despite the harm that it's causing socially to his family. And he's aware of this. And nonetheless, his decision-making is impaired. He makes a bad choice to go get drugs rather than get his kids out of the rain. So his disease, though, was tobacco, which is our legal and most deadly addiction in the United States. But honestly, you could substitute any image you want here. I've got a picture of a cigarette. We could put a bottle of liquor here. And the rhetorical question is, well, can marijuana result in addiction? And of course, the answer is yes. Could someone have impaired judgment? And could Mike have done the exact same thing if he was addicted to marijuana? Well, the answer, of course, is yes. And that, again, is my perspective, both from a primary care standpoint. Here's somebody who didn't recognize he had a problem. Now he wants help. The same is true for marijuana. So Nora Volkow, again, this is an image of her, really describes addiction as a brain disease and ultimately a disease of free will. And I'll take it a step further here to say, really, it's an impairment in cognition. When you think about Jonathan Cohen's description here of the cognition as being the ability to orchestrate thought and action in accordance with internal goals. Well, certainly Mike's internal goal was to take care of his kids, but nonetheless, his action wasn't congruent with that goal. So really here, what we're seeing is addiction as an impairment of decision-making. And to just put it all together, how does that fit into clinical practice? Well, a severe substance use disorder is our term for addiction. So somebody who continues to use despite harm, and the harm can be to both themselves as well as society, their family, their place of work. And if you want an excellent reference on the neurobiology of addiction, this is it. Again, Nora Volkow is the lead author on this fantastic paper from New England Journal. It's publicly available. And I put the last sentence of the paper on this slide, and it's really important for you to see that. If early voluntary drug use goes undetected and unchecked, the resulting changes in the brain can ultimately erode a person's ability to control the impulse to take addictive drugs. So that's a great segue into our first section, which is what are the health consequences of cannabis use? Well, again, I'm going to say right up front, whatever I tell you, you could find papers that counter that. It really is an area where we have an emerging and incomplete knowledge. One of the key factors to think about, regardless of what the consequences is, that addiction ultimately results from the interplay of genes and environment. And the drug can cause changes in brain mechanisms, and certainly marijuana is a drug that can do that. And the important thing here is that brain development is a factor that plays into this. So not only does the drug exposure and genetic susceptibility have a role, but when you expose a developing brain to the drug will have an impact on it. So when we think about this from a public health standpoint, our goal as a society should really to be prevent developing brains from being exposed to drugs that might change brain development. And if we think about that from a brain maturation standpoint, the first part of the brain to develop, the back of the brain, the cerebellum, the coordination that occurs in late infancy and early toddlerhood, is then followed by changes in reward and the development of motivation. Again, the exciting early years of toddlerhood. And then emotional development takes place later in adolescence. Finally, the last part of the brain to develop, the frontal cortex, judgment. Really, full myelination doesn't take place till the age of 25. So when we're talking about trying to prevent exposure to brains, we're really talking about brains even into the 20s, trying to prevent exposure to addictive drugs. And the frontal cortex really does drive behavior, and Sapolsky is a brilliant neurobiologist, and this is from his book Behave, which is 1,000 pages. It's quite a read, but it really tells you everything that we know from a molecular to a societal view about how human behavior is shaped. And the frontal cortex is really the driver of decision making, and the part of the brain that's impaired by drug use. So as I mentioned, there's an interplay between genetics and environment that ultimately results in health consequences. This is a field of poppies, which looks lovely, but it's also the source of opium. And we do have a lot of hostile environments for brains, for developing brains nowadays, whether it's inappropriate video technology for young children, whether we're talking about ready access to terrible foods that are bad for us. There's a lot of challenges in terms of developing brains. Here's an example of what we're facing. So this is a change in delta THC, the active ingredient in marijuana, the psychoactive component. You can see this rising concentration of THC. And if we took this slide back into the 80s, the THC rates would be down around 1%. So we have a much more concentrated drug that we're exposing people to. And unfortunately, we're losing a lot of ground when it comes to exposure of adolescents to psychoactive drugs. So this is from the data National Survey Monitoring the Future. It's based conducted through the University of Michigan. And anything you see red on the slide here is an area where we have a significant increase between 2018 and 2019 in terms of use by 8th, 10th, or 12th graders. And you can see nicotine vaping, tremendously high rates of nicotine vaping in the past year and past month among 12th graders. A quarter of 12th graders are vaping nicotine. Likewise, because vaping is an access now, so easy to access, people can vape marijuana. So here we have high rates of marijuana, a very concentrated drug now being delivered in a particularly easily absorbed fashion. And you can see with marijuana use in 8th and 10th graders, daily use has gone up. So lots of consequences. And unfortunately, in our society, we see an inverse correlation between perceived risk and use. So when perception of risk is low, use goes up. And you look back into our peak marijuana use by 12th graders in the United States was back in 79, 80. Well, that's also, again, the marijuana was much less potent than it is nowadays. And here you can see we are now at a period where perceived risk is quite low, and it's been dropping since 2013. And use remains fairly high among 12th graders, although not as high as it was back in the late 70s. And one more epidemiologic thing before we talk more about consequences. So daily use, this is the real marker of addiction. Young adolescents who use daily are the ones most likely to go on to have significant consequences and ultimately develop addiction. So 6.4% of 12th graders in the United States in the 2018 survey were reporting daily use of marijuana. You can see this rapid increase in 12th and 10th graders as well, up to almost 5% of 10th graders using marijuana daily. So to illustrate the consequences, I think this case is a sad one that I saw a couple of years ago. Young man who started in high school with alcohol, marijuana, benzodiazepines, stimulants, had comorbid depression that was never treated, and he was caught dealing drugs in college, placed on probation, kicked out of college, went to inpatient treatment, got started on antidepressants. He continued to smoke cigarettes, but otherwise did very well. And on my initial evaluation after he came out of treatment, I'm seeing him now as part of his ongoing probation. He's in sober housing. He's going to support meetings. He's working full time. He's doing drug testing through probation. Still has mild depression despite the fact that he's on 3 medications. He has no interest in quitting tobacco. And I asked him, what's your commitment to long-term abstinence from alcohol and other drugs? But particularly we're having a conversation about alcohol because he began using alcohol long before it was legal. And at this point, he's 22, and now he can drink legally, but he can't because he's on probation. And he gave me a really insightful answer, which is, let's see what my brain says when I'm done with probation. He really understood this. He was not completely yet developed from a brain standpoint, and maybe this probation time was going to be good for him. And there's a quote from one of my favorite authors who really understands the terror of adolescence and describes it as the most stressful and frightening period of human development. David Foster Wallace unfortunately committed suicide, and we lost a great voice. But he really understood this conflict, this yearning for childish oblivion, while at the same time wanting to be an adult. So what about marijuana's effects on the brain? This is a nice graphic that really shows that there are cannabinoid receptors pretty much everywhere in the brain, including the hypothalamus, which controls appetite and explains why people might eat a lot after they've smoked marijuana. The basal ganglia, which controls planning, initiation, motor control. Amygdala, which is responsible for anxiety, emotion, fear, are all well enriched in cannabinoid receptors. The cerebellum has a lot of cannabinoid receptors, and so you can imagine there might be issues with coordination and motor control. And then the hippocampus, important for memory and learning, also very enriched. And then finally, how we process information in the neocortex. So lots of places where cannabinoids have a potential effect. This paper is a little old, and the Institute of Medicine has come out with a newer one, but I still think it really does a nice job of looking at the adverse effects of marijuana. Again, this paper is publicly available. You can see Nora Volka was the first author on it, and it shows us some of the effects of short-term and long-term heavy use of marijuana. So impairments in short-term memory, impairments in coordination, altered judgment, and in high doses, paranoia and psychosis can occur when people are using marijuana and the cannabinoids. And then when we think about long-term or heavy use, addiction occurs in about 10% of users overall. But you can see 17% of those who begin in adolescence and 25 to 50% who are daily users are likely to go on to develop addiction. Alterations in brain development, poor educational outcomes, increased likelihood of dropping out, lower IQ scores among frequent users. Now it's hard to really look there are no really great controlled trials of marijuana use. You can't randomize people to using and not using. There have been some studies that have discounted some of the effects on adolescents, but again, these are small studies, and from a long-term standpoint, there are certainly people who are going to have consequences from their marijuana use, particularly heavy use. So going back to our case, it's hard to say what his gateway drug was because he started alcohol, tobacco, marijuana, all about the same time. He was stable for many months when I saw him. His depression continued to be mild, but then his father died unexpectedly from very rapid death from cancer. So at this point, in sort of despair, the patient violated probation, and in this case, it was alcohol use that led to relapse. He was sent to jail unbeknownst to me, and he died in a drug and alcohol binge after his release from prison. In this case, he died from a fentanyl overdose. He'd never used opioids before, but the impairment in decision-making from the alcohol and drug use led to him doing something he hadn't done, and he died. So ultimately, again, this is the worst consequence of addiction, but one that patients are much more likely to face if they have a severe use of a substance, cannabis being one. So in clinical practice, how do we address this? If you're not already familiar with the craft, this is the tool that's best used for screening adolescents for substance use disorders. If you are in family medicine, pediatrics, there's going to be some question related to the craft on your exam at some point. And it's a really nice tool. And the first question, actually, you can ask that of any adolescent, whether they're using alcohol, tobacco, or nicotine. The first question is, have you ever ridden in a car driven by someone who was high or using? So that by in and of itself is a risk, even if the person themselves that doesn't use drugs, if they're riding around with even a parent, could be a problem. So this is what the craft looks like as a screening tool. First, you let the patient know that you're going to ask them a few questions and that their responses will be confidential. And you ask about alcohol, then you ask about smoking, any marijuana, anything else to get high, and then you go on. The nice thing about the craft is it also gives you a little bit about the context. So not only you know if they're using, but you know something about how they're using and why. So are they using to relax? Are they using when they're alone? Do they use it to forget things? So a really nice screening tool. You're going to find, when you screen, you're going to find some things that you have to deal with. So what do you do with the adolescent who says, yeah, I'm using marijuana, but it's not a problem? So I'm going to tell you about a model that a colleague of mine, Dr. Eric Ayers from Wayne State, had been using for a long time in clinical practice. We adapted this from a model that Kevin Wildenhouse at Henry Ford developed. It's a brief intervention. And I have to mention that, with adolescents, the use is very common, as you've already heard. What we really need to do is prevent progression from use to disorder, because ultimately, preventing use is a public health initiative that goes beyond clinical practice. So what you're really trying to do in clinical practice is, once you've identified use, tracking it and helping to intervene if things are getting worse, or monitoring to make sure things are not progressing. And Heather's a great example of this. I saw her in practice a couple of years ago, a high school student who wanted help with opioids and stimulants. She's a non-smoker. She occasionally uses alcohol. She has near daily cannabis use, but that's not a problem. She really doesn't want any help with that. She just wanted to stop the opioids and the stimulants. So here's the WARN model that Dr. Ayers and I have been using, and we've taught this to students and residents for a long time now. So it's a brief intervention. It's based on the trans-theoretic model of behavior change. It's really designed for long-term use in clinical practice. So you ask really 3 questions. One is about the drug itself and any problems it might be causing. Second, would there be anything good about stopping your use? And then the third is, what would be hard about stopping your use? And these are nice questions because they're non-judgmental, they're non-threatening, but they create some cognitive dissonance and they get the young person to think about what's going on. You can use this in an adult too. And then finally, the end, the WARN, is just sort of a way to summarize to help make sure you're on track. So here's what it might look like in clinical practice. So I asked Heather, is marijuana causing any problems? And she pointed out, well, some of my friends would like me to stop. And then I asked her, well, if you stop, would anything get better? And she'd say, well, I wouldn't have to lie to my mother. So I've already got some insight that, she has some non-drug using friends, and she has enough of a relationship with her mom that she cares about whether she lies to her or not. I asked her, well, what would be hard about stopping? And she mentions it would be hard to stop using before school. And I learned by asking that question that she's really trying to ameliorate anxiety and that difficult feeling of going to school and not feeling write about yourself. And so marijuana helps block those feelings. And then the end in this case is really, a way to summarize what we've heard. It's really important when you're working with young people to make a clear message that you're concerned about the health effects, that you're not endorsing use of marijuana. I'm worried that marijuana is going to have some problems for you, but I also want to know if there's a change, and it's important that we have an open dialogue about this and that this is a confidential discussion. So through working with Heather, we were able to get her to talk to her mom about her desire to quit and get her engaged in family therapy. So when it comes to treatment, the National Institute on Drug Abuse, again, Laura Volkow is the lead of that, has created some principles around adolescent substance use disorder treatment. It's very similar to the treatment principles that you would see for adults, which I think has 10 on it. There's a few more for adolescents. I just want to point out a couple of things on here. So number 6, treatment should address the needs of the whole person. This is important for anybody, but if you really just focus on drug use, particularly with adolescents, you're not going to get very far. You really have to look at the entire individual. And then number 7, behavioral therapies are effective in addressing adolescent. And then number 8, families and community are important aspects of treatments. This is one of the biggest challenges, is even in a resource-rich area, if you have a patient that has good insurance, it's still going to be hard to find good counseling. And it's also hard to find families who are willing to engage in it. Most of the time, they want to just sort of say, you fix them and send them back to me when they're better, when ultimately the adolescent's use is in the context of the family, is partly enabled by the family, and the family is critical to success. So people always ask about treatment. Really hard to find treatment. There is for those of you who are health professionals, Substance Abuse Mental Health Services Administration has a treatment services locator. I use it all the time. You just put in SAMHSA find treatment in your search engine, look for the one that says .gov and it's SAMHSA. Having said that, very hard to find adolescent treatment, and even if something shows up in the locator, you're still going to have to call and find out if it's still something they do. University of Michigan Addiction Treatment Services does see adolescents, and that's where we might send a lot of our youth who need more intensive services if they're in the county. And then finally, we mentioned we're going to talk a little bit about prevention, because we're not going to treat our way out of drug-related problems. I show you this slide here. It's about alcohol, but you'll notice this is an area where the US isn't the worst. We're actually like right in the middle of the road in terms of heavy drinking among teens. Well, why is that? It's because of the National Alcohol 21 law. And that's a major factor in reducing adolescent access to alcohol use. Now, again, access varies a lot across the country and across parts of the country, but this is a public health initiative that has had a big impact. We're losing a little ground. Fortunately, now we have nicotine is not regulated at the age of 21, but tobacco is. We really need to get nicotine on the no use before 21 law as well. And if you don't believe me, you'll read this paper, and it's really scary about nicotine as a gateway, particularly around stimulants for adolescent brain development. So if you use nicotine as an adolescent, you're more likely to go on and use drugs like cocaine or amphetamine. So this paper is frightening, but really well done, and another reason for us to advocate from a public health standpoint for protecting developing brains. So when it comes to prevention, NIDA has a paper on that as well. These are the prevention principles when it comes to children and adolescents. It's really beyond our scope to go through it, but I do want to talk about a real life scenario, which is Iceland. So Iceland in the 1990s had the highest rates of tobacco and alcohol use among teens in Western Europe. They were kind of the joke of Western Europe. Now, Iceland is a small country. It's less than 500,000 people, less than 1 million people, and quite homogenous. But as a society, they decided they needed to do something about it. So they actually went from the highest use in Europe to the lowest rates of use among teens. What did it take? Basically, it took strong parental messages that it's not okay for kids to drink and drive, or to drink and smoke. It's not okay for your brains to be exposed to these substances, and that we're going to provide alternatives for youth, particularly kids who are at higher risk. So those who are alone after school with no parental supervision. And they basically created extensive network of activities that involved kids, regardless of what they were interested in, whether it was sports, music, dance, art. There were things that kids could do, and they're really a sort of a model for what can be done from a public health standpoint. So in closing, what can we do as members of society to have an impact on all drug use among adolescents? Well, reading well by the 3rd grade is actually one of the best predictors of future good health outcomes and low rates of drug use. So early childhood education, particularly pre-K, is critical for high-risk children. And along that, early education and wellness, really understanding health and wellness early on. And then supporting sober environments. So marketing is a huge problem in that all the cannabinoids are marketed. It looks like it's safe. It looks like it's fun and cool. That's a problem. We really need to decrease marketing and the exposure of people to the message that cannabinoids are safe. Decreasing access the way we've done with tobacco 21. And taxes do have an impact on adolescent youth, because if things cost more, they're going to be less likely to use it. Once somebody develops an addiction, they'll pay any price. And then support for treatment. So early treatment, harm reduction. So if reducing the consequences of those who do use drugs in terms of health is important. And then this integration of the justice system and drug treatment. If I had known my patient was in jail, I could have been there when he got out. And then finally, decriminalization is important. And then legalization, it sort of depends on how you approach it. Legalizing without the marketing is sort of what the Netherlands has done, and they have very low rates of drug use. Portugal has the lowest rates of drug use, and all drugs are legal. And again, it's because they put money into treatment, and it's still illegal to deal drugs. So I think we've got 10 minutes left for questions here, and I appreciate your attention. Thank you.
Thank you for that. We can open it up to people actually asking questions or continuing to put them in the chat if you have any.
Dr. Hopper, I have a question. How would you advise parents who are trying to have a conversation with their children curbing usage, or trying to get fairly honest conversations in the home about cannabis?
Yeah, I think again here it's going to have a lot to do with what does communication look like in this home to begin with, and has there been open communication before, and also parental recognition of what's been their role in terms of role modeling. So one of the major problems we have here in Washington County in particular is that there's a lot of very permissive attitudes towards cannabis among parents. And if there are permissive attitudes, whether it's cannabis or alcohol, people letting underage use, that ultimately is the source of a lot of problems. So people have to get honest about that. And if they have been enabling in the past, they're going to have to say, we've really come to realize that this could be harmful. And if there is suspected use, a lot of times you are going to need some help to negotiate it. It might need to be done through counseling or through a physician, and getting physician involved as sort of a neutral mediator to begin that conversation may be helpful, or through counseling. But one of the first steps is ultimately for the parents to look at their own role in terms of, have they been enabling, have they been potentially role modeling permissive use.
Thank you. We do have a couple of more questions in the chat now. I'll start with, do you have any advice on how we might reduce marketing, increasing legal nicotine age, etc.? Tips on advocacy.
Yeah, this is great. I mean, Washtenaw really led the way in terms of Tobacco 21, and this was certainly an initiative from the previous public health director, Dr. Marshall. I think working there is a national organization on Tobacco 21, and I think working through legislators and getting more awareness of, it's not tobacco per se, but it's really nicotine. And this paper is, in and of itself, again, it's a very detailed paper, but the conclusions, anybody can realize how dangerous nicotine a drug is. This New England Journal paper by Kendall. So yeah, I would say working through whatever community-based organizations you can to restrict access to tobacco at the local level, but then also think nationally about what can be done. And Tobacco 21 is a fantastic organization to be involved with.
Thank you. Let's see, we have another one. I have seen from Terrence, I have seen a great increase in marijuana use since we started using the RAAPS questionnaire. My question is, how can we manage patients on stimulant medications who are also on marijuana?
Yeah, so this is a frightening combination, patients on stimulants and marijuana. Stimulants are the most reinforcing drugs we have, and ones that people particularly like using, and we have very few treatment options for. So if they're on stimulants, I think one thing to step back and look at is, are stimulants appropriate for this person? Do we have the right diagnosis? Do we have the right treatment? If they truly have a diagnosis of ADHD, particularly for adolescents, they generally don't like taking their stimulants. And are they using them? That could be a problem. If they're not using their medications, they're actually more likely to go on to use cannabis. So undertreating ADHD is a problem. If they are taking their stimulants, then I would say they may be in need of additional treatment or counseling. And usually you're going to need a complex mental health evaluation through a psychiatrist or a psychologist, and ongoing counseling. Yeah, very, very challenging situation.
Thank you. Another question. What is your opinion on adolescent medical marijuana use? Is that a little more of a gray area?
Yeah, so I would say it's similar to nicotine and alcohol. There's widespread use, and we should expect that there's going to be widespread use as long as it's so readily available in society. And what we're really trying to do when we're seeing patients at the clinical level is monitoring for the progression of that use. So that using that WARN model, are things changing over time? Was something that was a warning before now part of their daily practice? So if you ask them what would be bad about use, they said, well, if I started to buy it, because right now I'm getting it from friends. If now they're telling you they're buying it, you can sort of remind them, this is something we had talked about, it might be a problem, maybe we need some additional help. So really tracking over time at the primary care level is the key thing, because use is going to happen. You're not going to be able to prevent use at the clinical level. All you can do is monitor for progression and then intervene when things are progressing.
And here's another question. When I think about harm reduction in our society, does expert advocacy really work? What role do taxes and prices have in limiting access?
Yeah, so there's two parts of that. One is, does expert advocacy really work? Well, yeah, unfortunately, lots of policy is not driven by expertise. That's definitely true. But I think we are fortunate, at least in Washtenaw County, that our representatives do tend to listen to science and experts. Now, when it comes to taxes, yeah, this is something that the literature is very clear on, that taxes don't do much to stop anybody from using once they have developed a substance use disorder, whether it's alcohol or nicotine. But when it comes to adolescents, they're much more elastic in terms of their use. And as prices go up, their access is going to be limited. They're not going to have the money to pay for it themselves, and people are going to be less likely to buy it for them when things are expensive. So before you've developed an addiction, you will make decisions based on costs. And it's very clear in areas where taxes are high, adolescents are less likely to use nicotine, well, tobacco and alcohol. And again, it's one of the reasons why we need to be taxing more on things like Juul and vaping devices.
I do want to echo your point on advocacy, that we are fairly lucky here in Washtenaw County. Both the health department and the Washtenaw County Medical Society are members of the Keep Michigan Kids Tobacco Free Alliance. And the Alliance is heading into a very busy fall legislative calendar. And we will be, very active on issues like this coming up. So stay engaged in your professional societies and keep an eye out on your email.
I see we have just a little time left, and I can see some of the chat there. I want to thank Dr. Joyner from U of M for participating, and he wants us to be aware of a podcast called Kids Being Kids, which provides insight into the lives of adolescents. So thank you, Dr. Joyner. That's an excellent reference. I want to mention from Charles Wilson from the Health Department mentioning that there's a question about, can you be physically dependent on cannabis? And yes, that is possible. About 10% of people have a physical withdrawal syndrome when they quit cannabis use. And then finally, there's a question about what medication can be useful compared to medical marijuana. So this is a really broad topic, but I will say we don't have any medications that can help treat marijuana use. In terms of what can be substituted, that would be an entirely new talk.
Great.
Great.
All right. Well, I think that will likely wrap it up for this afternoon. Thank you very much, Dr. Hopper. Our next session will be held next Tuesday, September 1st, with Dr. Mark Weiner of St. Joe's also. And you can sign up in the web box here below or on the website. Susan, any other closing thoughts?
No, just thank you. This was a great discussion. And I'm not sure if did we get this question from Facebook? If we have just a few more seconds, what medication can be useful compared to medical marijuana?
Yeah, unfortunately, it's too broad to answer, but
Okay.
that there are no treatments available. By the way, I'm using Dr. Weiner's computer, so we can say that it'll work for next week as well.
Awesome. Thank you. We're prepared. Great. Well, thank you everyone for joining. And again, you can sign up for our next sessions. The link is in the chat, or visit washtenaw.org/medical marijuana or our Facebook page to see this session. Thank you.
And we'll be posting the slides on the website also with Dr. Hopper's permission.
Yes. Yep. Thank you.
Great. Thank you very much. Enjoy the rest of your weeks all.
Thank you.